Okay, good evening, everyone, for those in US and Europe and in Australia and the Pacific and Asia. Good morning. Thank you for joining me. Today's session is just a little bit about planning, and I've got quite a few fellows that come through, particularly our wonderful AO Spine fellows, who are always trying to pick my brain about how we plan these complex cases. And they do take a lot of, I suppose, cognitive a load to sort out some of these cases and a bit of time to think. And I thought I'd just run down the process on a case with a bit of everything. Matt Goodwin was going to do today's session, but was unavailable, so I've stepped in for him. So it won't be as long as always, but I can't see any of the other faculty here at the moment. Hopefully they'll be joining soon, but I will try to answer the chat box as we go, and feel free to fire in any questions. I'd also got to thank Amna, who works tirelessly in the background. She's Ali Baja's research fellow, and just does a fantastic job of sorting us all out for the weekly meeting. So thank you, Amna. You don't get enough recognition, I think. So I'm going to get started on this case, and I'm just going to work through the planning process as to how my thoughts go with this type of surgery. So when you look at these sort of revision and complex cases, there is always a good story. Very rarely is it straightforward. And this is a patient who at 59 years of age had this surgery done. This is a multi-level operation done for a combination of stenosis and mild deformity. He has seronegative psoriatic arthropathy. He's on some of those newer agents, biological agents, and had been on methotrexate in the past. So his first surgery was done in 2021 for a combination of stenosis and scoliosis, and it was an entirely reasonable procedure done from L2 to S1 with a L2 to L5 PLIF. And surgery was done by a very good surgeon, competent surgeon, actually one of my fellowship supervisors from 14 years ago. Surgery was done under O-arm guidance, all posterior approach, and he had no immediate complications, and he actually felt good after surgery, mobilized quickly, and went back to regional Australia, where he's from, with good relief of symptoms. So unfortunately, within a year, he came back with problems. So in 2022, he presented with severe bilateral leg symptoms and lower back pain. And you can see that his adjacent segment has basically had early and catastrophic collapse. And so what we're going to designate here at the L1-2 segment, knowing he has a transitional level, he's got that complete vacuum disc sign. And you can see here at the back, there's a huge area of calcified, sort of partially calcified disc material that's pushed out into the canal. So he was taken to the public hospital where some of my friends and colleagues work, and he underwent an emergency surgery. And again, I think the surgery performed was entirely reasonable. He had a posterior approach and decompression to remove those huge fragments in the canal. And then he had a PLIF at L1-2 to fill that disc space and extension of instrumentation up to T11. And he made an initial good neurological recovery from that. But he ended up with some complications. And like all these patients who have inflammatory arthropathy on potentially immunosuppressant medications, they can run into trouble. So he had some incisional drainage post-operatively, and then ended up presenting in a somewhat delayed fashion, a deep infection with an epidural abscess that was diagnosed on aspiration as staph epi. He underwent IV, then oral antibiotic treatment, as he wasn't overtly neurologically compromised. But subsequent CT imaging showed that he had screw loosening at the top of the construct, so quite a degree of cavitary change. You can see there around the screws, which have cut into the end plate. He's also got a cage sort of haloing in subsidence of those bilateral PLIFs that you can see there. So This was his status at referral to me. He's now 62 years of age. He's on oral antibiotics under supervision of infectious diseases. He's got quite significant pain at the thoracolumbar junction. He has a forward posture and positive sagittal balance. There are some of his numbers there, but basically he's got a coronal shift to the left, 60 millimeters. He's got an SVA, which is clearly abnormal at his age, of 114 millimeters. Now, this is where it always gets complicated, and what I do usually for these patients with a transitional level, which is what he's got, where L5-S1 is not mobile due to a Bertolotti lesion, I do not take the S1 end plate for his pelvic incidence. If you do that in this case, he's got a pelvic incidence of close to 80 degrees. Which I don't think is the true functional representation. So I usually just take a midline across the L5 body and then use that to measure the PI up to the sort of true last lumbar level. So if you take that method, he's 45 degrees, but he's still got reduced lumbar lordosis of only 17 degrees. So you need to determine a few things. And I think the first thing when you're considering these revision cases is the patient neurologically damaged or the impending risk of major neurological injury. And I think with a combination of aspiration and IV antibiotics, his epidural abscess has kind of settled down, which is good. You can see the MRI there, which is taken on a 3T scanner. So there's quite a bit of artifact. I think one thing to say is if you work in a big spine center, having access to a 1.5T MRI scanner, which in my opinion is all you need for most spine pathology, is absolute gold, because it really helps you look around that metallic artifact, which is so prevalent on 3T scanners. And so there's a real kind of an argument and dichotomy between what other specialties want and what radiology wants and what we want as spine surgeons. I think you have to be able to document the spread of the infection. And here we used an FDG PET scan. I know not everyone has access to that, but this was very, very helpful. And you can see uptake on this scan in the L1/2 interspace. And that is diagnostic of infection around those cages. And you can also see the uptake heading further up around the screws that are haloed out. Bone quality is important to assess, and I think this patient had bone mineral density testing that showed that elsewhere bone quality was good, so that's a good thing. You need to know what the existing implants are, and fortunately this case was operated on by two surgeons who I know who work in my state. Easy to get notes and easy to find out what those implants are, but we get cases from around Australia, around the world, which can be very difficult to determine what they are. Knowing what implants are can go to your reps. They can be very helpful, and an experienced rep often knows exactly what the implants are. I don't know if the audience is all familiar with the Facebook group, which is called the Spinal Implants Identification Group. Just a quick plug for that group, because they're actually a source of gold information on what implants are based off plain x-rays. We know this patient's had prior spinal surgery, but when I'm doing revisions, I really want to know what prior abdominal surgeries the patient's had as well. Fortunately, he hasn't had any major ones, but I'm using lateral, oblique, or direct anterior abdominal access for a lot of revision approaches, and knowing what they've had done in a prior abdominal surgery is very important. And then potential further surgeries are also a big consideration for me. So, just having a look at this patient, and if I go back a slide, this patient not only has an infection with proximal junctional kyphosis and implant-related issues, but also got a sagittal balance issue and a relatively young age. And I'm just cognizant that might need to address that in the future with other procedures once we can solve the current problem. I do not think in the situation of infection it's appropriate to go doing an osteotomy at the moment. So I think it's really important you bring a few friends with you, and this is myself and Dr. Chris Samiklis, who's my former fellow, but a very good surgeon, friend and colleague who referred me the patient. He'd done his last procedure. I think you do have to consult with your company and industry representatives, and that's a super important uh, connection that you've got there, not only in identifying the implants, but working out what you've got to use, talking through every step of the case. And in this case, we were able to get some pre-contoured and pre-made rods done. And I think that's going to be incredibly helpful for going forward. I think hopefully the timeframes to get them are continuing to reduce, and more companies will be able to offer them. I think we talked about implant identification, and trying to get original drivers and removal equipment is very, very helpful. There are generic removal kits available, but having the ability to remove implants without having to do too much fancy footwork to get them out is helpful. Implant removal in orthopedics is often seen as simple, and it can actually be some of the hardest operations that you do. There is always the option of cutting rods with screws locked and just winding them out. And in this case, we know they're loose and some of them are just going to fall out, but you don't really want to have to go helicoptering out every screw on a piece of cut rod. I think the other thing that's always in my mind is not burning bridges for later. Obviously, respecting soft tissues in a multiply operated infection case. Do not be afraid to get plastic surgery involved. We did not need them here, but have a very low threshold for involving plastics. But I think the other thing when you're planning these cases is you should never be afraid to stage surgery and to ultimately stage intervention. So, yeah, we don't get it right all the time. I think what you want to do is give patients stable constructs so they can potentially mobilize. But again, infection, absolute contraindication here to a major osteotomy, in my opinion. So we really wanted to avoid that. So what I'll do is I'll just run down my plan for this patient, and I certainly discussed it with my colleague Chris. We were trying to do things initially in a single stage and in one position if possible. Now, he's not actually sick, which is great. He's relatively young, so we can do things in an open fashion, but went here with a prone position because of the infection. We did not use cell salvage. Wanted to make sure that I had lateral access available to the L1-2 disc space. We had O-arm and fluoroscopy available. Now, I think that if you're starting out, you probably should also be using neuromonitoring for this kind of case. At L1-2, I don't feel it's actually necessary for the prolateral approach. There is not enough of psoas in the lumbar plexus there to really worry about it. So I didn't use dedicated neuromonitoring initially in this case. Basically had to have a plan where we took out the infected stuff. So we planned removal of implants on T11 down to S1 with multiple samples taken, although we didn't know what the previous bug was, and a debridement, and then closed that entirely and basically then did a whole new setup. And so we then did a prone lateral approach was planned for L1-2 for cage removal, and that's a tricky approach. You've got to work between the ribs, but usually you can stay extrapleural for that. That does require some careful planning off the preoperative scans. And look, when you look at them, what to fill that gap with, I'm a big fan of titanium in infection. I think titanium is the most friendly material in an infection, and I use bioglass, so no allograft. You're going to use bioglass, which for reasons of changing the local pH of the tissues is again a friendly graft alternative in the infection space. And you can load antibiotics into that as well. I think here, again, respecting the soft tissues, planning on doing a less invasive approach for some temporary or bridging fixation. And so we could look at doing pelvic fixation with iliac screws through lateral incisions away from the previous midline incision. And to do that, I have done it under fluoro before, but navigation is very, very helpful. The navigation we used for this case was an O-arm and stealth, but there's lots of different platforms available you can use. And by using navigation, we're able to get in big implants in a good lateral position. I was able to lace T6 to T8 MIS pedicle screws as well, with the O-arm available. And then we were planning on rod passage, basically using an MIS passage lateral to the prior incisions and to lock the whole construct in. So to keep some stability there while we allowed for clearance of the infection and healing. So this was our setup for the prone lateral component with surgery. You can see the lateral retraction there. The posterior incision is there. This is our approach for getting out the cages. A little video is going to run here, and sorry about the background noise. This is using osteotome to loosen the cages and get over the top of them. And another trick that can be very helpful here is running a hip arthroplasty hook into the cage to help get them out. So a bit of disc prep going on there. And these are the two expandable cages that we removed from the disc space. They were loose, so they came out relatively easy, but this is all coming out through a 4-centimeter incision in the side. And this is the shot down the retractor. Hard to get good resolution at the base of it, but you can see it's a fairly minimal approach for cage retrieval there. And we are working here between the ribs. So this is the prone lateral approach at L12 for an expandable cage. And the final images there, but this just shows the cage expansion that you can get to just fill the space. And then the cage is further backfilled with bioglass and antibiotic powder to provide stable fixation. And this was our final construct. You can see there what we've been able to do with the Medicrea program and the pre-planning. So just go back to that. So this is the rod that we had pre-made, and we've been able to run it from T6 down to the pelvis. It just fit, which was good. I probably should have allowed for some more length to expand the cage, but we just got enough there. And pre-contoured rods are fairly new to me and a bit of a learning process. So we've got quad pelvic fixation, two long rods there spanning the affected segment. And everything else posteriorly is out there. The anterior cages that were infected are out at L12, and the other cages were left as there was no uptake there on the PET scan. So this is a case in progress, and I'm always happy to take comments or feedback on this sort of case. But I think here what we've achieved at the moment is bridging fixation, which is stable. We are allowing the soft tissues to heal in the midline and get control of infection in case we have to come back and do an osteotomy later on. I think we've been able to fill that unstable disc space with a decent size cage that's loaded with stuff that will hopefully help again relieve infection. And some of the principles here I use go back to the old orthopedic principles, in that if you get, say, an infected tibial non-union, just removing implants is never going to cut it. You need that stability as well. And when we did in tibial non-unions in orthopedic training, you'd use an X-fix. So the similar principle here. The reason I've gone to T6 with those screws is so that I can go up to T3 or T4 for a long deformity construct in the future if we have to. Fortunately, in this particular case, my patient is doing well, and I checked in with him just before the meeting. He's almost pain-free, mobilizing well, incisions have all healed. So this is just a little bit about a complex case that has both infection and deformity, and to show the sort of planning that goes into it. I appreciate that those pelvic screws may loosen with time, and if we have to, they will plan so that I can come back and do a lower S2AI screw and probably still get good hold in the pelvis. So with that, I'm finishing up this case. I've got to go operate myself, so it's a short session today, and apologies for that. But I'll take any comments on the chat. Love to answer anything, and I'll just have a look and see if any faculty have been able to join today. No, haven't got anyone at the moment, but if anyone's got any comments or thoughts on the chat or question here, please ask away. I am very aware that I'm lucky to work in a heavily resourced environment. I have a whole bunch of stuff that I know around the world is harder to access. I've got great retractors for prolateral. I'm able to do pre-made, pre-contoured rods. We've got intraoperative navigation, O-arm, and these films here on the final slide are long stitched films that we're doing with the current O-arm software to avoid long plate X-rays, which I do find a bit challenging to get. And just have a look at the chat box and see if there's any further comments. Good. Not too many questions on this case, but what I'll do is on LinkedIn and Twitter, I'll post the final EOS imaging when it's all done. And yeah, I think apologies for the shorter session today, just stepping in at a short notice, and got some time zone issues, but I'd like to thank everyone for joining, and we'll advise online on Twitter what we and LinkedIn what the session is for next week. So thank you again, everyone, and we'll catch up soon.